All right, good afternoon, everyone. I'm Kristen Steenerson. So I am a neurologist, but I have specialty training in balance and vestibular disorders. So my home department is otolaryngology, but I'm not a surgeon. All right, so I thought we would talk about the vestibular system and how it has differences between sexes. These are my disclosures. We'll go over the vestibular system, so there are both peripheral and central components, so meaning outside of the brain versus inside of the brain. We'll talk about those interactions and sex hormones with specific instances of vestibular disorders, so vestibular migraine, maldebarquement syndrome, and Parkinson's disease. So when we think about the vestibular system, I think most people classically think of that peripheral vestibular system. So Dr. Aliano already gave us a really good introduction to the peripheral cochlear vestibular system. The vestibular system is really highlighted by these main components. We have our three semicircular canals. Can you see that? Okay, good. Three semicircular canals. Those are our rotational or our angular acceleration detectors. We then deep inside have two linear acceleration detectors known as our otolithic organs. Those have embedded those otoconia that you hear so infamously causing BPPV and crystal displacement vertigo. When we think about vestibular disorders, most people are thinking about peripheral vestibular disorders. So they're thinking of anything that could be impacting these end organ and sensory organs. So the main things we think of are benign paroxysmal positional vertigo. We'll think of a viral infection or an ischemic event that could cause some damage to the inner ear labyrinth. There are some less common things that we can consider, like Meniere's disease, which causes progressive hearing loss and terrible vertigo attacks. But for the most part, this is what people are thinking of. What they're forgetting, though, is that the vestibular system has actually quite a bit more going on. So this peripheral vestibular system really focuses on the main question, am I moving? But we know that the vestibular system also answers the question of where am I? It's a very important construct for sense of self-perception as well as spatial orientation. So when we think about those central vestibular projections, so these are leaving the peripheral organ, they're entering the brainstem level and going up through the deep brain thalamic structures out to the peripheral cortical structures, we know that these are going to give us many different higher order cognitive processes. So visual spatial processing is very important vestibular function. By being able to create a framework, a 3D reconstruction of the world around you, you're able to make that memory palace. You're able to set down different types of memories. We also know that the concept of self is very important, so knowing where you are in relationship to the rest of the world is a very important vestibular function. Cognitive processing, so bringing all of those together in order to use that memory palace to do whatever you need to do as part of this vestibular network. Memory again, executive functioning, so planning is a spatial orientation effect. And then attention, so being able to actually execute all of these things in a timely manner. So looking at those components in a little bit more detail, we can see the various levels of central vestibular system functionality. So we can follow that peripheral organ again, sending those information bits through the vestibular cochlear nerve to our brainstem. Here we meet the vestibular nuclei, which have crosstalk between both sides, that then have projections to our deep brain with our thalamic nuclei. And then this is a little misleading because it's identifying just a single location in the parietal insular vestibular cortex, but we know this is actually a widespread array of cortical activity that's bihemispheric with every input. We think this is an important, well-preserved function because the sense of balance is such an important aspect of being a bipedal organism. So being able to stay upright, to know where you are in relationship to gravity constantly, has to be very well preserved in order for us to get through our daily activities. So the ability to take that peripheral input of motion detection and using those central projections to achieve these higher order cortical processes requires this concept of central integration. So this kind of just talks you through it, what we already just went through. But the idea is that you need this complex network coming together in a synchronized fashion in order to create that 3D reconstruction that helps you perform all those really high order cognitive functions. This is important because vestibular dysfunction is incredibly disorienting for patients. So we usually think of vestibular symptoms being spinning, so the sense of, yes, of course I'm disoriented because the world's moving around me. But you can have that sense of disorientation without motion necessarily happening in any respect. So it can create just a sense of disorientation or unease, discomfort with either the feeling of yourself in your own body or with the world that's around you, which is, I think, an underappreciated impact of vestibular dysfunction. So I wanted to bring this home a little bit and look at the women in my dizzy clinic. So I decided to just look at all of the percentages of females for some of my most common disorders that I see. So over 70% of my vestibular migraine patients are female. Over 76% of my maldebarquement patients are female. Over 70% of my persistent postural perceptual dizziness patients are female. And the average age is 56, which I think we can all agree is a relatively active time in terms of fluctuations in sex hormones. This, I think, is very demonstrative of what is found in the literature, that women are much more affected in these types of balance disorders, and we'll talk about that more with the following slides. So the first one I wanted to talk about is vestibular migraine. Vestibular migraine we affectionately call the chameleon among recurrent vertigo syndromes. That's because vestibular migraine can do anything. So it can cause hallucinations of motion, including rocking, swaying, tilting, room inversion. It can cause sense of self-disorientation, visual perceptual changes, visual motion sensitivity, known as visual vertigo. Vestibular migraine, it can be a little bit of a misnomer for some people. So when we generally think about migraine, we consider headaches. The most severe headache you've had in your life. It comes of times of stress, or dehydrate, or caffeine withdrawal, and then if you go to sleep, you're able to recover from that. Vestibular migraine is a subset of migraine, but it actually doesn't require headache. And the reason for that is that we're kind of revising our approach to migraine. When we think about migraine, instead of orienting ourselves based on the headache aspect of it, we're now orienting based on hypersensitivity. So what we think that means is that the brain is over-interpreting sensory input. So it's over-interpreting light sensitivity, sound sensitivity, smell sensitivity, motion sensitivity, and we've lost that inhibition of the central nervous system to bring that level down to a more tenable level that is not so overstimulating and frustrating. So along those lines, within that hypersensitivity section, we can think that motion can be its own hypersensitizing input. So motion sickness, most of us are probably familiar with. And then if we go to a next level from that, we can have vestibular migraine, which is on top of what we think of as a triggered motion sensitivity, you now have sporadic, spontaneous motion sensitivity. And with that attack, you can have, again, that chameleon picture where you can have spontaneous onset, spinning, rocking, floating, room tilting, what have you. That can be, for obvious reasons, very debilitating and very unpleasant for the patient who may not know exactly what's going on. It was at first considered potentially a diagnosis of coincidence or convenience. Dizziness is very common. 10 to 30% of us will experience some level of dizziness over our lifetime. Headaches are very common. 10 to 30% of us will get a headache at some point in our life. So was this just coincidence that these were coexisting? Fortunately, epidemiologic data has shown that's not the case, that there's statistically significant difference in these vestibular migraine populations. This could not happen just by chance. This has formal diagnostic criteria that have just been accepted since 2013, so it's a relatively new diagnosis in the medical community, which means a lot of patients are going undiagnosed. And what's interesting and what makes it so relevant to this talk is that there is clearly a sex hormone dependency when it comes to vestibular migraine's age of onset. So when we think about our changes in estrogen levels throughout the lifespan, we can think of kind of three core opportunities in our lives. We have puberty, we have childbearing age, and then we have perimenopause, menopausal status. This, interestingly, also represents the three peaks of vestibular migraine activity. So puberty, we think mostly of females, can start to have random spinning attacks that we will call benign paroxysmal vertigo of childhood, so a subset of vestibular migraine. Childbearing, we think of vestibular migraine in its classic sense. And then we can have perimenopausal onset of vestibular migraine, which the classic story is someone who's had traditional migraine, terrible severe headaches with light sensitivity, sound sensitivity, and nausea, who then improve once they start to go through menopause. The headaches go away, but now they start to develop these terrible dizzy attacks that seem spontaneous and nothing like they've experienced in the past. We think this connection with estrogen relates to the concept of menstrual migraine. So menstrual migraine is its own topic within the International Classification of Headache Disorders. It is a headache or a migraine that occurs only with menstruation, but it's helped to build a framework for understanding estrogen's contribution to migraines in general. We know that what happens, or we think that what happens at the end of the luteal phase as we have estrogen withdrawal, that there is an increase in migraine-related activity, and we'll get into the mechanisms for that. So similarly, we see that pattern in vestibular migraine, that is, patients get closer to their menstruation, they will start to have more intense vestibular symptoms, or they'll have their vestibular attacks that occur somewhat spontaneously. So reasons behind this estrogen sensitivity are plenty. So we'll talk about a few main theories that are out there. This is an example, very basic schematic. They actually put the midbrain in the wrong place, but basic schematic of where estrogen expression and estrogen receptor expression in the brain is. And you may notice that this has a lot of overlap with that basic vestibular system that we talked of in terms of central vestibular system. So just highlighting main areas, we have brainstem activity, hypothalamus, thalamus, and cortical projections, similar receptors with the trigeminal nucleus, the thalamus, and the cortex. So reminding ourselves a little bit back to that central vestibular system, lots of overlap between those. Similarly, we can frame this in the context of migraine theories. So we know that migraine is a very complex neurogenic process that involves multiple modalities of pathophysiology. Some of the main theories that exist are neuroinflammatory peptides, so CGRP, known as calcitonin gene-related peptide, is an inflammatory peptide found throughout the central nervous system, the peripheral nervous system, and pretty much every organ system that you can think of has CGRP, but it has been identified as a main neuroinflammatory peptide that may be part of the migraine cascade. New medications have just come out targeting this that have been very successful for some patients, so it seems like a sustained theory. Prostaglandins also have inflammatory contributions to these neurogenic episodes. We know that brainstem hypersensitivity, specifically trigeminal nucleus, trigeminal ganglion hypersensitivity, can act as a generator for this cascade of migraine type event. We know that vasoconstriction and vasodilation, either as end effects or as generating effects, still to be determined, do still play a role in all the migraine process. Cortical spreading depression, which is the concept of this spread of electrical activity over the cortex, as well as serotonin level changes in the brain. Now, there have been quite a few studies looking at estrogen and the roles of all of these. Whenever we see multiple arrows, it means we don't know what the answer is, but it is very interesting that there have been papers that can support estrogen as a role in every single one of these processes. One that I would like to highlight is the trigeminal nucleus. So that trigeminal nucleus we think of as the generator for the trigeminal-vascular system. So that's creating pain. That's also creating vasoconstriction, vasodilation effects in the central nervous system. Why that's particularly important related to estrogen and vestibular migraine is that we know that trigeminal nucleus and trigeminal ganglion have direct inputs to the labyrinth. So this is a very clever study that was done in the 90s that looked at injections of biocidin into the trigeminal ganglion. They're able to trace that dye into these end organs of the labyrinth. So you're able to find dye in the cochlea, in the labyrinth, meaning the vestibule, so the semicircular canals, the otolithic organs, and then that eustachian tube, which can be very problematic for a lot of migraine patients. It's a very interesting connection between potentially estrogen, brainstem hypersensitivity, and vestibular migraine. Other theories that have existed have looked at mouse models where they have done oophorectomies of the mice and have looked at their responses to what we think of of paradigms of migraine pathophysiology. So placing irritating chemicals on the brain cortex with the open brain and giving them actual electrical activity that can spread through to mimic cortical spreading depression. They've measured CGRP levels in those mice models, and they can measure then that level of activity compared to the non-oophorectomized mice. And they find that statistically significant changes, meaning that the mice are much more sensitized to those types of migraine processes in the absence of their estrogen generators. Moving on from vestibular migraine, we can talk about maldebarquement syndrome. Maldebarquement syndrome, a lot of people have heard of it, but just to make sure that we all have a good background of this is the concept of not getting your land legs back. So the classic story you hear is someone goes on a cruise, they get off the cruise ship, and it's like they never got off. They feel this persistent rocking sensation no matter what they do. By definition, it lasts at least a month after whatever passive motion exposure that they had. Maldebarquement syndrome is interesting in terms of hormonal influence because of the epidemiology. So average age, 48 years, 9-to-1 female to male ratio, so exquisitely female influence. And population studies show a high association with migraine and motion sickness. There have actually been quite a few theories out there offering that maldebarquement might be a subset of migraine. More likely, it shares a lot of the pathways that migraine shares. So looking into this association a little bit more, a lovely group out of Europe asked motion-triggered maldebarquement patients to keep track of their menses and to see what their symptoms did around that. And they found statistically significant levels of aggravation around their menses. They also found that they became much more migraine susceptible once they had onset of maldebarquement syndrome, again, tying in that migraine pathophysiology. And then interestingly, they did a retrospective analysis where they asked patients to dot back and figure out when their menstruation was in relation to their passive motion exposure, so that cruise or that plane ride or that car ride. And they found that the majority of them actually were having menses during that passive motion exposure. To go a little bit deeper into that, they also looked into a subset of maldebarquement patients who became pregnant. They asked them to keep track of their symptoms, and they found that during pregnancy, their symptoms improved, and then postpartum, their symptoms came right back to the level that they were previously. So this really has caused a lot of speculation about what hormone fluctuations may be doing in response to maldebarquement syndrome. So first, we have to think a little bit about why does maldebarquement happen? So thinking that this isn't a subset of migraine, instead we're going to look at some core processes within the vestibulocerebellum. So the vestibulocerebellum is that center part of the cerebellum that helps with prediction and velocity storage. So that idea is that your cerebellum has to actually be able to predict what motion you're going to experience in order for you to have a time synchronous experience. Meaning that if you have a lapse or a delay in that experience, you'll have mismatch, which will make you even dizzier, make you even more motion sick, motion sensitive. So vestibulocerebellum is exquisitely reactive to being able to predict motion and train the brain to kind of cancel out that motion, if you will. And so what we think happens in maldebarquement syndrome is that velocity storage becomes very vulnerable for some reason. Its exposure to that passive motion retrains it into this new state of motion that is then irreversible after the motion stops. So you can't revert back to what your normal sense of stability is. And interestingly, these patients love motion after this happens to them. They are motion seekers. They want to get back on the cruise. They want to get back on the train or the plane because that's the only time that they feel normal. That motion sensation has finally been canceled out again. So the theory that has come from this is that we know the neurons that are part of that vestibulocerebellum are very GABAergic. They're very sensitive to GABA changes. And we know that estrogen withdrawal can cause a loss of those GABAergic neuron sensitivity. So we think that there is this change in the GABAergic network that causes this velocity storage mechanism to become very vulnerable to those motion changes, creating this staled state that occurs when on menses, when exposed to those types of passive motion. They've tried this out looking into trying to figure out treatments to see if there's a way to counteract that. And they have found that through optokinetic training, so giving your brain a visual motion stimulus that can cancel out that perception that you've been retrained, can actually help reverse that sense of perceived motion. So these optokinetic training exercises they've done, which are usually these either complex dot arrays or complex stripe arrays, are put at a specific speed, and then the patient is asked to actually mimic their perception of rocking. And over 70% of these patients who were motion triggered, they can have resolution or significant improvement in their sense of perceived motion. it's really, really interesting. I think we still need a lot more information understanding the pathophysiology and understanding the relationship to estrogen for potential other therapeutic targets, but still amazing that there's been this type of breakthrough in just the past few years. So not all doom and gloom when it comes to hormones. I'd like to talk about estrogen and Parkinson's disease. So as you may recall, Parkinson's disease, we have a loss of our substantia nigra production of dopamine, which can create movement disorders where patients become bradykinetic, so very slow. They lose expression. They can create tremors. They've lost our normal sense of motion and movement. This is a really interesting study that came out in the early 2000s, 2006, where it did these mouse models looking at estrogen as potentially a neuroprotective influence for specifically this substantia nigra, pars compacta, to see if there could be a protective effect, as population studies have shown that men are much more likely to develop Parkinson's disease, and that can even out postmenopausally, where women start to catch up. So they found in this mouse model that estrogen was very neuroprotective in the most inflammatory circumstances that they could come up with, but still this was a mouse model. Was there much that could be really translated from this to human studies? Flash forward about 13 years, and this nice study just came out looking at supplemental estrogen in the treatment of Parkinson's disease. So this is a very interesting study where they took naive patients, meaning drug naive, postmenopausal patients, and they divided them into two groups, low-dose estrogen and high-dose estrogen. For the two-group comparisons, they kept track of their motor symptoms, they kept track of their overall sense of well-being, they kept track of their drug levels, so how much medication are they actually needing in terms of carbidopa, levodopa, the classic medication we treat Parkinson's disease with. And then they watched them over months and months. And what they found, statistically significant lower levels of medication required, so from 10 milligrams down to 7 milligrams for those that were on high estrogen, better mood scores, better motor scores too. This is a very preliminary study, new in terms of what are going to be the long-term effects of this. We still don't know any of those answers, but still a really interesting adjunct to those initial animal models showing that neuroprotective effect from estrogen may be very helpful. One of the mechanisms that they looked at was keeping track of their dopamine transporter accessibility and availability, and they found that the higher level estrogen, they had more dopamine transporter availability than the low estrogen or than the no estrogen situations. So really, really exciting direction that things are going from a neuroprotective standpoint. So an overview of what we just discussed. We know that estrogen is associated with central nervous system balance disorders. We know that those fluctuations are probably more problematic than anything, and they can aggravate particularly those migraine-associated disorders. We have an idea that estrogen is neuroprotective and may actually have a therapeutic role in some neurodegenerative conditions. And then last point that I really want to drive home is that understanding this relationship with estrogen, it obviously offers important therapeutic target treatments for patients, but it also helps women understand a little bit better what's happening to their bodies. So our experience in our clinic is that many of these women have been told that these are over-exaggerated symptoms, that it's in their head, that they've been dismissed by their practitioners in the past. So just giving them a story, a narrative that helps their brain understand what's happening to them actually gives a lot of power and control back to this patient population. So thank you so much.